Hello, I'm Matteo Simonetti, multimedia producer at The Lancet, and I'm here with Chloe Wilson, senior medical editor at The Lancet Weekly, to talk about a new podcast called The Lancet Pulse. Hi, Chloe.
Hi, Matteo.
Tell us something about this new channel.
Well, we're launching this new podcast, The Lancet Pulse, on February 23rd, and I'm really excited about it.
Yeah, me too.
In the Lancet Pulse, editors are going to be joined by subject experts to discuss some of the hot topics in medicine, and it's supposed to cover a really broad and diverse range of areas. Think artificial intelligence, psychedelics, xenotransplantation, just to name a few. And it's not necessarily related to a piece of content that we've published, but instead it's supposed to break down what could be quite complicated or controversial areas in a really engaging way, and not just through discussion from experts, but also through discussion with the editors, highlighting what's upcoming in that subject area, as well as some key takeaways from the discussion with the expert.
Thanks, Chloe, for this introduction. For our listeners, you can search for The Lancet Pulse on your favorite platforms from February 23rd and join the conversation.
Welcome to The Lancet Voice. It's early February 2026. I am Amy Slowgrove, Senior Editor for The Lancet Child and Adolescent Health. And I'm delighted to be joining Jessamine Baganel, your familiar Lancet Voice host, to co-host today's pediatric-focused episode of The Lancet Voice. In May 2022, a World Health Assembly resolution was adopted on strengthening clinical trials to provide high-quality evidence on health interventions and to improve research quality and coordination overall. That resolution recognized the central role of community stakeholders in the clinical trial ecosystem, as well as the neglect of children in clinical trial investment. So those working in clinical trials will recall, I'm sure, that in 2025, updates were published for the SPIRIT standard clinical trial protocol items and the CONSORT guideline for reporting randomised clinical trials. And at the Lancet Child and Adolescent Health, we are very excited to be now co-publishing the first child and adolescent extensions to the SPIRIT and CONSORT reporting guidelines that will be known as SPIRIT Child and Adolescent, or SPIRIT-C for short, and CONSORT Child and Adolescent, or just CONSORT-C. And we'll be co-publishing these along with the BMJ and JAMA Paediatrics later in February. So today I'm so delighted to be joining Jessamine, as well as the two leads on the SPIRIT and CONSORT Child and Adolescent project, to talk more about these extensions. We're really excited to have Baba and Martin Offringa joining us today. Ami studied neuroscience in Toronto, completed her master's in brain sciences at University College London. She's currently a research project manager at the Hospital for Sick Children in Toronto, the lead author of the SPIRIT-C and CONSORT-C guidelines, along with Martin, who's a neonatologist and a clinician scientist at the Hospital for Sick Children and University of Toronto. He's a clinical trial methodologist, has been involved in many pediatric trials in newborns, infants, children, and adolescents, evaluating both acute disease interventions and chronic rare diseases. Ami and Martin, welcome. Thank you so much for joining us today on The Lancet Voice.
Thank you for having us.
Thank you for having us.
I think a lot of our listeners will know already that the SPIRIT and CONSORT statements are mainstays in clinical trial protocol design and clinical trial reporting. And as medical journal editors, we interact daily, particularly with the CONSORT statement for clinical trial reporting. But perhaps we can just start off with sharing what the need was to develop a child and adolescent specific extension to these already widely used reporting standards.
Sure. Over the last 15 to 20 years, in pediatrics, we've learned a lot about developmental biology. And we actually learned that at various stages of the development of a child, their responses to interventions like drugs or non-drug medical intervention is not quite predictable by extrapolation from older children or from adults. Actually, there's a field called developmental pharmacology, where it shows that the same dose, calculated per kilogram body weight, leads to different levels in the blood, because the liver of the child is, for example, very active at the toddler age, and then later, drugs are staying much longer in the system. Same with the kidney function. That's not a linear thing. And we've also learned from observations and further case studies that the response to the same drug level in a child is really related to at which age stage the child is. As a neonatologist, we used to sedate our babies for procedures, but if you give the same drug in the same dose to a toddler, they get really excited. We call that developmental pharmacodynamics. And so all of this together, and I'm not even talking about the psychological development and how outcomes are changing over the lifespan of a child, we call those ontogenetic variabilities. And they can actually be quite surprisingly large. And that's why, at each different stage, outcomes differ, the way you give interventions. The benefit-harm profile of any intervention is almost never constant across the ages. So we learned that, and then trials, including, children at different stages of their development, they failed. They didn't analyze it, and they didn't describe what happened for these smaller children and school children and even teenagers and adolescents. We need to talk about, what is really done in a trial and what is found with some extra details for the children and for the different age groups. The other reason was that people were looking at the record and started asking for guidance. Then what is the minimal set that we need to report for a given trial in children? So when this started was really when I was working as a clinician and I was, trying to implement evidence. And I started developing clinical practice guidelines myself, doing systematic review of trials, and I found that it was completely challenging to combine and to compare trials, because everybody was reporting some different details, different ways to administer interventions, different outcomes were measured and analyzed and reported. So it was really difficult to tease out, like, signal from the noise, if you will.
Yeah, just to add to what Martin said, existing reporting guidelines, including SPIRIT and CONSORT statements, right now they don't capture pediatric-specific considerations. So even if authors use SPIRIT and CONSORT statements and adhere to them, they may not be addressing details that are pertinent or important for pediatric trials. So some of these details include the justification for including certain age groups, reporting on any developmental related differences in treatment effects. There may not be enough details on number of children and adolescents involved by pre-specified biologically different age groups, whether they were randomized, like balanced by randomization, and specific intervention doses and formulations used, and adjustments based on the age, their weight, their body surface area, and also any mitigation of anticipated burden, stress, and harms from trial procedures may not be addressed. So because children don't respond to interventions like small adults, and they're not small adults, even within the pediatric population, there's a lot of heterogeneity from the newborns to infants to children to adolescents. There's a lot of differences in their anatomy, their physiology, their psychology, and how they respond pharmacokinetically and in their pharmacodynamics. So we really wanted to create guidelines to address some of these details because they are critical, and so that key information is not lost. Readers can understand what was done, what was found, and what the results mean for them, and research efforts aren't wasted.
Jessamy, I wonder if you want to push a bit more there, being the surgeon amongst us and not sort of already convinced of the need for children and adolescents, whether you have any skepticism about that statement and consort didn't do this well enough already.
I don't have any skepticism that this was something that was needed. It's 100% needed. I think in at least the biomedical field, we always have a tendency to assume that children are just little people and that we can apply all of the same things that we would to adult medicine, to pediatric medicine. And that's for a number of different reasons. Partly it's because they don't have a voice. There are issues of competency and consent. There's always the guardians who are the main point of contact. But it's also because it's easier. And so anything like this, which really draws attention to the fact that it is different, that researchers, clinicians, healthcare professionals need to think differently, both in the way that we conduct research, but in the way that we actually manage patients and people as well, is crucial.
Yeah, and something else that was really unique about this process that you went through was the extent to which you engaged caregivers and young people themselves in contributing to the development of these reporting statements. So I wonder if you talk a little bit more about that process.
So the development of SPIRIT-C and CONSORT-C involved young people and family caregivers. And involving them, we were able to work on reflecting their priorities in the guidelines. So for example, youth-generated items, we were able to work with young people to understand what they wanted to see reported in a trial protocol or report. So they actually generated new reporting items for consideration in the reporting guidelines, and they were included as part of this consensus process. So, for example, we had items on the intervention delivery and whether a support person is needed. Youth also thought that items on recognition for their time and contributions in participating in a trial was important to be included. They highlighted concerns about confidentiality and whether their individual participant data will be shared. And all of these items were really important, and we heard them during the workshops we had with youth. It made a lot of sense to include these items and highlight the practical considerations that youth consider are important to them.
And I might just add that for me, as a clinician who's been there for some time, we didn't steer, what they were going to say at all. But it was really, for me, like the eye-opener, because we really, in adult trials, we always presume that they get compensated or they are protected and their data are protected. But we never ask children anything. So they came up with this themselves. And that was really something that I feel, although it may not be like in the core of the biological, things that are going on in intervention testing, I thought it was really good. And so we added that to the checklist just as a sort of a new chance. And the children were really vocal and they really had their opinions. The other thing is that they also validated, completely unprompted, some other child-specific reporting items that we had already on the radar. And we call them youth-supported items in the papers. So they weren't new, but they came up with those items themselves, and we felt that they really validated those items for us.
That's nice. Can I ask a question? What do you see as the major barriers to the implementation of these guidelines? And have you had, during the process of working with young people and the broader group, what did you identify? What are you expecting when these papers are released?
When we worked on developing these guidelines, we really wanted to involve young people and also family caregivers because they are end users of trials. We really wanted to hear from them on what they think is important, because this isn't something that we can learn from the literature, but only through directly working with them. However, to our knowledge, this was the first time that young people from the age of 10 years were involved in the development of reporting guidelines. So figuring out how best to involve them in this process was a challenge for us, because we wanted to make sure that involving them wasn't tokenistic and it was meaningful for them as well. So in order to do that, we worked with individuals who have a lot of experience and expertise in facilitating young person advisory groups, and also with patient engagement experts to really figure out how best we can involve young people in this work. So we co-designed the involvement of young people in this project with them to make sure that we're presenting reporting guidelines in an understandable way, and also to facilitate meaningful discussions with young people who were interested in contributing to this work. And we also offered flexibility to young people and families on how they can be involved in the project based on if they were interested and if they were available, if it was something that they found valuable.
So we learned a little bit from the colleagues that have developed SPIRIT. Dr. Anwen Chan was on our core team, and of course the famous David Moher, who invented CONSORT almost 25 years ago, I think. Have they been successful in implementation, and has the uptake there been like spectacular? No, not yet, and that's an ongoing sort of process, I would say. For us, it's going to be important to get across the message that these guidelines are not intended to be a hurdle. They're really based on the minimal set, because that we really set out to reduce all the possible, but really this minimal set that goes for all trials, and actually a few items they say, when applicable, which means that probably there are trials that don't need to worry about those reporting items. But we really want to make the point that this really are the resources that will help standardize what is reported in child health trials, so that eventually these research efforts do not get wasted. And we've all heard about research waste. That is a concern everywhere, but also in our field. So I think, if trialists and journals, editors and peer reviewers are paying attention to this minimal reporting requirement, then I feel that they can make a real difference. The research will impact healthcare decision-making through systematic reviews and guidelines. It will actually help improving health outcomes. And the recent WHO guidance on clinical trials and the updated Helsinki statement on research with humans, they really consider the use of reporting guidelines as responsible research practices. So I feel that the new generation should really pay a little bit of attention, because again, the adult-focused trialist may think that this is an extra hurdle, but we've just learned it's not that simple, especially if you want to sort of study an intervention across, a broader age range, like asthma, like, a new inhaler. And we know that, in toddlers, it may worsen the asthma, while in adolescents, they may improve. So before you include any child in your trial, we would say, team up with a pediatric subspecialist that understands these ontogenetic variabilities across children, and then figure out how to make the most of your trials.
Thanks, Martin and Ami. It's just leading on from there. I mean, I'm thinking about their relevance in low and middle income countries where there's already limited trial infrastructure. I think only about 10% of all trials registered over the last 2 decades have actually been in child or adolescent age groups, and only 10% of those, so sort of less than 0.1%, are actually in children that are experiencing the highest burdens of morbidity and mortality in low and middle income countries. And so, I mean, one of the things that I think I'm positive about is that, these guidelines can help to reduce research waste, to improve the validity and the quality of the results we have at the end of the day. But we also know lots of really small trials get done in children. They're often underpowered. And so I wonder what you think about sort of that benefit of it, of, people being able to improve the quality of individual but small trials, and having more success at then synthesizing evidence from these trials at the end of the day to be able to answer questions.
Right. So this is really the big question in our field, because as you probably know, that most diseases in children are rare diseases. Not like the diseases that need trials, like, middle ear infection and sore throat, but it's really the diseases that bear high mortality in the higher income countries are rare, as compared to, of course, what you talked about, the low income countries. With respect to low and middle income countries, we set out and we involved pediatricians and trialists from those regions through our Center for Global Child Health here in Toronto. And we got very interesting input, not only about some reporting items, but also about the feasibility of collecting data in those settings for these outcomes. And people were generally not concerned so much that this would only work like, in the Western world and not in the low and middle income countries at all. So I was really happy with that input. No, so when we're talking about small sample size, that is actually what we're used to in pediatrics. And therefore, it's so important that each data point, can be used and it doesn't get lost because people are unsure what to report, or they don't use sort of standards that are out there to classify children in age groups, and instruments that are validated, that, outcome measurement instruments validated in children are used more and more and more in trials. Used to be like, the outcome is a biomarker or, something that sort of, you can be measured in 1 week, but more and more we're looking at functional outcomes in children. Can they participate? Can they go to school? Can they play with their friends? But there are scales for that. And so we need to know whether the instruments are valid and reproduce and generating more signal than noise. So here, I hope that these are reporting guidelines. These are not about designing trials, but they sort of pay attention to those sources of variation that actually can destroy trials, in the sense that it completely undermines your power if your instrument is generating noise and not a signal.
These reporting statements will be published on February 24th. We're hoping for good uptake and the world to start using them. But perhaps just to round our conversation out, what do you have planned in terms of the next steps on dissemination and supporting uptake of the use of these guidelines?
So, of course, we are so excited for these papers to come out on February 24th. And the dissemination and uptake is so important, and it's a whole nother process we have to consider, because we are trying to change research practice, author behavior, research institutions, journals, and funders when they review protocols and also reports. So first of all, to make it easier for guideline users, we prepared explanation and elaboration papers, or E&E papers. They will be published in the BMJ on the same day, on February 24th, to accompany these guidelines. They provide examples of good reporting and also explanations for each item so that they are applied in the way that they're intended to be. We're also preparing, aside from that, tip sheets for each new SPIRIT-C and CONSORT-C reporting item, and also a short informational video about the guidelines. So if anyone wants to learn more about each item or about the guideline, these may be useful resources. Really, when we were planning the publication of these guidelines, we really wanted to reach a broad readership and an international reach. So we are co-publishing these statements in multiple journals, the Lancet Child and Adolescent Health, the BMJ, and also JAMA Paediatrics. So that is part of our dissemination and reach. We also worked with the Lancet Child and Adolescent Health on a special feature highlighting the patient and public involvement work. And also a patient page is coming out in JAMA Paediatrics about what young people and family caregivers need to know when they're reading a clinical trial report. We have also been working with other journals for publishing editorials, and we are planning to present this work in the future in webinars as well. So we're trying to really hit different audiences publication-wise, but also afterwards beyond that.
And what we're really hoping, obviously, is that all journals that publish trials with children will pick this up and endorse it and put it on their instruction for authors, so that it doesn't take 20 years, like it did for Consort, the original adult version, but that we can make progress a little bit faster with these child health trials.
That's excellent. I think that's where we're going to have to leave our conversation today. But just a huge congratulations to you and your teams, to all of your collaborators, partners that have been on this journey with you and now get to see these really important guidelines coming to light. You have the full support of the Lancet Child and Adolescent Health and the Lancet Group in supporting uptake and implementing of these guidelines. And thank you for joining me today.
Thank you.
Thank you for having us.
To our listeners, we'd encourage you to have a look at the SPIRIT-C and CONSORT-C statements, consider how they're relevant to your work in child and adolescent clinical trials in designing and reporting them. And at the Lancet Child and Adolescent Health, we will be requiring reporting according to the CONSORT-C extension. Both reporting statements are available at thelancet.com with a link in our show notes, as well as links to other content in relation to global health clinical trials that we've discussed today. Remember that you can subscribe to The Lancet Voice and The Lancet Child and Adolescent Health in Conversation With, wherever you usually get your podcasts. Thanks so much for listening, and take care.